My name is Dr. Mark Rolfe. I'm the Medical Director of the Lung Transplant and Adult Cystic Fibrosis Centers at Tampa General Hospital. The presentation I'm about to give deals with the ideal management and referral for lung transplants for patients with idiopathic pulmonary fibrosis. The current lung allocation system in place allows patients with usual interstitial pneumonitis and IPF to be listed ahead of most other patients for lung transplant. Unfortunately, we're often referred patients who have undergone unnecessary invasive diagnostic workups which preclude consideration for transplant in this disease process with no other hope for cure or remediation. Hopefully at the end of this presentation, we can understand and appreciate an appropriate non-invasive workup of usual interstitial pneumonitis and appreciate the appropriate referral pattern and speed at which a referral needs to be made for patients to be considered for successful lung transplant. In the 1970s, usual interstitial lung disease was lumped together with a number of other interstitial lung processes. It wasn't until appropriate clinical analysis of the clinical course of these diseases and the histopathological correlation came along that we were able to generate a diagnostic schemata that helps us better understand and appreciate the appropriate referral pattern and treatments for these patients with variable types of interstitial lung disease. Currently, we recognize UIP and IPF, desquamative interstitial pneumonitis, non-specific interstitial pneumonitis, LIP, and acute interstitial pneumonitis as a different disease process in each case. The diagnosis of these disease processes then places the patient in a referral and treatment protocol which is somewhat unique for each disease process. For the purposes of this talk, UIP and IPF will be considered the same disease process. Demographically, there's approximately 30,000 or more patients diagnosed per year. The prevalence is greater than 80,000 current patients with this diagnosis. The age onset is 40 to 70, with patients in the 60s to 70s at most common presentation age. 2/3 of the patients are over 60 years of age at presentation, and males outnumber females. In Florida, with our retired population, we are in a hotbed for this disease process and should be considered in the differential diagnosis of anybody with shortness of breath and interstitial changes on their chest x-ray. This slide presents the epidemiology of IPF in bar graph form. As can be seen in these two graphs, the incidence of usual interstitial pneumonitis, or IPF, is peaks in the patients between 65 and 70, males predominant over females. The prevalence, likewise, is in an elder population between 65 and 75, with the highest number of active cases of usual interstitial pneumonitis. If there's one take-home message of this presentation, it is that you do not need an open lung biopsy to diagnose UIP. When you see honeycombing and fibrosis on a chest CT, an open lung biopsy looks the same no matter what the initial cause was. Open lung biopsy is potentially dangerous, especially in high-risk patients with pulmonary hypertension. It can also jeopardize the only known therapy for UIP, and that would be transplant. It also increases the morbidity and mortality associated with transplant in patients with open lung biopsies, as there's increased bleeding and often a prolonged hospital course from that standpoint. We would recommend that you do not do open lung biopsies on any patient who is a potential lung transplant candidate without first referring the patient for evaluation at a lung transplant center. The clinical diagnosis of UIP or IPF requires you to gather some basic information. In the history and physical exam, patients over 50 are more likely to have usual interstitial disease if there's a gradual onset of symptoms with progressive dyspnea on exertion, a non-productive paroxysmal cough, bibasilar crackles on auscultation, and in about 25 to 50% of the patients you can even see some digital clubbing. Pulmonary function testing is often helpful. In UIP, there's a restrictive ventilatory defect with a reduction in the total lung capacity or forced vital capacity, a normal FEV1 to FVC ratio, and in fact this ratio can actually be above normal. You'll also see impaired gas exchange as the interstitial disease impedes AA gradient matching, and with that, you'll often see exercise desaturation. There are a number of serological tests that may help narrow the diagnosis of UIP. There are connective tissue diseases which can be affirmed or discounted based on the presence or absence of an elevated SED rate, an ANA, a rheumatoid factor, aldolase levels in the case of myositis, anamyocyte antibodies such as anti-Jo1 antibodies in scleroderma, extractable nuclear antigen panels which can be seen in mixed connective tissue disease, and p-ANCAs for those patients who have underlying vasculitises. Many patients with sarcoid will have classic findings of hyaluradenopathy and interstitial lung disease, and in end-stage sarcoid you can still see elevated ACE levels. In hypersensitivity pneumonitis cases, the pattern is more micronodular, and a hypersensitivity panel and exposure history can lead to a differential diagnosis and often the appropriate diagnosis without open lung biopsies or even transbronchial biopsies. In the appropriate setting with the appropriate symptoms and negative serology, the clinical assessment is all that is necessary. An open lung biopsy will often hasten the decline of these patients. As mentioned before, can be hazardous in patients with coexistent pulmonary hypertension, a condition that's seen in anywhere between 20 and 60% of the patients. As mentioned, it can also exclude patients from subsequent transplant consideration. In patients who present de novo with interstitial lung disease in the appropriate age group and appropriate clinical scenario, serological testing including the SED rate, ANA, rheumatoid factor, CPK and aldolase, Jo1 antibodies, ANCA levels is probably all that's needed to effectively rule out secondary or connective tissue disease associated lung damage processes. There are classic radiographic findings that correlate with UIP and IPF as well. A high-resolution CT scan will show bibasilar peripheral reticular nodule abnormalities with the lung bases involved typically more than the apices, especially early in disease. You'll see subpleural honeycombing, which becomes more prominent over time, with minimal ground glass opacifications. Late in the course, you'll see traction bronchiectasis with thickened interlobular septae. All these findings, along with the negative serological evaluation in the appropriate age group, are highly associated, almost pathognomonic for UIP. There are certain features in a high-resolution CT scan which should make the pulmonologist consider alternative diagnoses. A pleural effusion is very uncommon with IPF and almost rules that diagnosis out. Significant pleural thickening, moderate ground glass opacifications, scattered nodules and cysts are all subtle findings on CT scan that would make a physician think that UIP is not the clinical diagnosis. For better accuracy, it's recommended that prone scans be performed as they show more subtle abnormalities and are easier for the radiologist to correlate with the appropriate clinical diagnosis. In the year 2000, the American Thoracic Society and European Respiratory Society published a joint paper in the American Journal of Respiratory and Critical Care Medicine, in which, using major and minor criteria, the diagnosis of UIP could be confirmed with high probability in a clinical fashion. The major criteria included exclusion of other known causes, which would be done with serological testing, evidence of restrictive disease or impaired gas exchange, which would be done with pulmonary function studies, high-resolution CT scans showing classic radiographic changes, and a transbronchial biopsy or BAL that does not support an alternate diagnosis. Minor criteria include age over 50, insidious onset of unexplained dyspnea, duration of illness greater than 3 months, bibasilar inspiratory velcro crackles. To make the clinical diagnosis, it's necessary to have all major criteria and at least 3 of the minor criteria, and a high likelihood that this disease process will be UIP precludes the necessity of the patient undergoing an open lung biopsy. After the clinical diagnosis of UIP is made, there are predictors of poor survival. Oftentimes, the pulmonologist and the transplant center are referred patients relatively late in their disease course. Looking at the 6-minute walk, the forced vital capacity, the mean pulmonary pressure, and the diffusion capacity allows us to risk stratify patients for rapid evaluation and transplant consideration versus clinical studies to see if there's alternative methods to abate the progression of this disease process. Data published in the American Journal of Respiratory and Critical Care Medicine in 2003 by Lama et al. Demonstrated that patients with desaturation with ambulation on presentation with a clinical diagnosis of UIP have a significantly higher mortality rate at 1, 2, 3, 4, and 5 years. Hence, a patient who you see as an initial diagnosis with UIP should undergo a provocative oxygen desaturation test with a 6-minute walk trial. Those patients who have desaturation events should be considered for transplant evaluation and referral immediately. For those physicians who like to look at pulmonary mechanics, Collard et al. Published in the American Journal of Respiratory and Critical Care Medicine in 2003 the results of their evaluation of the rate of lung function decline to mortality in patients with IPF. As can be seen in this graph, those patients who are improved have a significantly greater chance of surviving 10 years with UIP. Patients with stable and particularly patients with declining FVCs have an associated markedly increased 2, 4, 6, and 10-year mortality. And in fact, if you look at the graph, in patients where there's a decline of greater than 10%, 10-year mortality is approaching 100%. For physicians who like to follow the diffusion capacity, Latsy et al. Published in the American Journal of Respiratory and Critical Care Medicine in 2003 their observations on patients with UIP who had a declining diffusion capacity and their overall survival. As can be seen in this graph, those patients who had a significant decline in their diffusion capacity at any time during follow-up had a markedly worse survival than those who did not. One important clinical feature of pulmonary fibrosis that is associated with shortened survival is pulmonary hypertension. All patients diagnosed with idiopathic pulmonary fibrosis, either clinically or by open lung biopsy, should have a right heart catheterization or at the very least an echo with Dopplers to determine the degree of pulmonary hypertension. Patients with a mean pulmonary artery pressure greater than 25 have statistically significantly shorter life expectancy than those with less than a mean pulmonary artery pressure of 25. The elevation in PA pressure is a relatively common feature in patients with advancing UIP, but can be seen early in the disease process as well. In patients with early UIP, desaturation with exercise is associated with the existence of underlying pulmonary hypertension. It is also a very important clinical feature for the transplant pulmonologist in making the decision whether a patient should undergo a single or double lung transplant. And one of the most important reasons that an open lung biopsy in patients with UIP can preclude them from subsequent double lung transplant consideration, as the biopsied lung becomes scarred to the pleura, increasing the risk of bleeding and post-op complications associated with cardiopulmonary bypass necessary for the double lung transplant. Prior to 2005, when transplant lung offers were based on time on list, it was obvious that patients with usual interstitial pneumonitis and interstitial lung disease died at a significantly higher frequency than those with COPD. To deal with this survival disadvantage, UNOS developed a lung allocation score, in which the patient with the higher score, not the longer time on list, was offered the lung. The lung allocation score was developed looking at old transplant data as well as transplant listing and survival data without a transplant. Patients with IPF were then given a augmented score such that their on-list mortality dropped significantly. It also became obvious that transplant was the only therapy available in 2005 and still today to extend life expectancy in patients with UIP that is progressing. Any patient with a clinical diagnosis of UIP should be referred to a transplant center for transplant consideration. We live in Florida, where we have a substantial elderly population. It is imperative that patients even past 65 be referred for transplant evaluation and interventions made that need to be performed to make the patient ready for transplant consideration. At Tampa General Hospital, physiological age is more important than chronological age. Between June of 2002 and April of 2009, we transplanted 23 patients between 60 and 65 years of age. We had an 83% one-year survival and a 70% three-year survival. Between June of 2002 and May of 2009, we transplanted 48 patients over 65 years of age with a 94% one-year survival, a 76% three-year survival, and a 66% four-year survival. These data are better than or equal to any transplant program in the country, even using patients whose age is beyond the normal accepted 65 cutoff. I hope you found this short presentation informative. Please feel free to visit our websites, newlungassociates.com, where you can obtain data for referrals and review our program and personnel. For patients and for physicians, the website lungtxp.com has slide presentations, statistics, and a chat room for patients to discuss the transplant process and our program. We invite you to call our program 813-844-7137 with questions and fax any referrals to 813-844-8960. Thank you very much.